Okay, good afternoon everyone, and today we are going to cover some of the important topic that is from our respiratory disease of the respiratory system that must be asked in our exam. Okay, so starting with we will cover important as well non-important topic in single lecture from the respiratory point of view with respect to our medicine subject. Starting with the our defense system. Okay, what are the lungs special defense mechanism that help in the prevention of our and decreasing the uh, cause of disease. So first is our lung defense. Lung defense usually protect us from the particle, gases, well the infectious agent, dust, soot, mold, fungi, bacteria, and various things that get deposited in our airway and alveoli. Okay, so how they will protect by using some of the special defense mechanism are available. First is our hair cell as well the mucosal secretion. Okay, what the function of mucosal secretion is trapping, and the nasal hair will help in the removal. Okay, same thing written here that over 90% of the particle greater than 10 micron that get trapped by the mucus as well the hair in the nose. After that, humidification. What is humidification? It happened in the nose and the upper respiratory tract that prevent the dehydration of the epithelium. What will happen if epithelium get dehydrated? It will get dry and started infecting. Okay, so and next is our coughing, sneezing, and the gagging reflex are that will help to excrete out the particle. So this is the physiological mechanism to expel out the any particle or the foreign body that get inhaled. Okay, and after that, what are the mucociliary layer in our respiratory tract? The epithelium of the respiratory tract, it is covered by the layer of the mucus secreted by the goblet cell and the mucus gland. So you have to remember that there are the two. First is goblet cell, second is the mucus gland. These are the two that secrete the mucus. Okay. After first point that we have to remember in this point, and next is respiratory ileum is also covered by the cilia, which are in contact with the under surface of the mucus layer. So first thing is mucus, as we earlier we have studied that mucus and the cilia both are helping. So first is our mucus that gets secreted by the goblet cell and mucus cell, and second one is our cilia that is just present below the mucus. Okay, after that small particle get trapped in the mucus blanket, and the cilia push the mucus blanket upward along with the trap particle. Next is cigarette smoking reduce the ciliary action, and in immotile cilia called as cystic fibrosis. Okay, as we all know that increasing inhaling cigarette smoking cause the decrease the motility of the cilia, and which resulting in any what is cystic fibrosis, any disease that could causing the decreasing the motility of the cilia either anywhere of the throughout our respiratory tract, either in the trachea or in the nasal cavity. This is we called that is included in our cystic fibrosis. Okay, so there is the reduction in the ciliary function as well, the leading to the stagnant. So if cilia is not functioning, that whatever the secretion or that get accumulated in our on the site in the nasal cavity, okay, that lead to at the end infection. Okay, so what are the 3 points we have to remember in this section? That is the function of mucociliary. In first is our mucus secretion, about mucus secretion, and second is about the cilia, and third is if the cilia get immotile, it will resulting in our cystic fibrosis, and the end result will be recurrent infection. After that, lysosome, lactoferrin, and the peroxide are also present in the mucus. As you know by their name, their function are understood. So this substance help in the non-specific first line defense in the invasion of the microorganism. Okay, next is our secretory IgA. Okay, immunoglobulin F function is to this is present in the mucus secretion that provide local immunity within the lumen of the airway. So what we have to remember is it provide the local immunity. That is our important point. Okay, and next is our alpha 1 antitrypsin, that is and alpha 1 antitrypsin. This is present in the lung secretion that functions to primarily inhibit the chemotrypsin as well the trypsin, and then neutralize the protease elastase which cause the damage to the lung tissue. Okay, we will later study in the emphysema that how the irritation cause the activation of the protease and elastase, and the resulting in the damage to the lungs tissue, that resulting in emphysema or breathing difficulty. Okay, later we will watch. Okay, next point is our cellular defense. What is the cellular defense? First is the epithelial cell of the airway. How epithelial cell? This produces surfactant. The very most important point that that which increase the phagocytosis as well the killing of the microbes, and another function is to keep the moist throughout our in all the lungs tissue presenting. Okay, that is the function of our surfactant protein. Where it get produced by our epithelial cell. Okay, epithelial cell produce the surfactant. After that, next is our pulmonary alveolar macrophage. What is the function of pulmonary alveolar macrophage? This always, as we all know, function of macrophage is only that is phagocytosis, the foreign body and the bacteria that is the alveoli. Next is our lymphoid tissue present, that the lung contain the large number of the lymphocyte which is scattered throughout the airway. And the lymphocyte, what is the function of lymphocyte? As we all know, its function is to contribute to the local immunity by through differentiate into the IgA secreting plasma cell. Okay, whatever if it found the foreign body or anything in the respiratory tract, it get convert itself into the plasma cell which secrete IgA antibody, and function of IgA is to maintaining the function. Okay, let's we summarize what we have studied till. Okay, so we have studied the lungs defense mechanism. First is our hair cell and the mucosal secretion. Second method is humidification, and the third mechanism is mucociliary movement, and the fourth is secretory IgA, and the fifth one is alpha 1 antitrypsin, and sixth one is cellular defense. Cellular defense includes three things, that is epithelial cell first, and second is alveolar macrophage, and the third is our pulmonary alveolar macrophage. Sorry, third is our lymphoid tissue. Okay, this is a little about our lungs defense mechanism. Next is our what are the pulmonary function test or vital capacity. Okay, or peak expiratory volume. We will just look it briefly. First of all, what is pulmonary function test? It is used to just measure the airflow rate, lungs volume, and the gaseous exchange across the alveolar and the capillary membrane. है ना? So if any disease that affecting the above, we can assess that by pulmonary function test. Many test results depend upon the effort of the patient, suboptimal effort, and it is a common cause of the misinterpretation. As you all know, if patient take deep breath during that, then it will change our interpretation of the test. All the pulmonary function tests are measured against the predicted value and derived for the large study. What is the indication of the pulmonary function test? That is one of the important. First is to assess the severity and the type of the lungs dysfunction. Second is the diagnosis the cause of the dyspnea and cough. So any disease in which the symptom is dyspnea and cough, we will go for the pulmonary function test. Second is the monitoring the lungs function in certain occupation like high risk of the lungs damage like mine worker. Okay, so we will routinely assess the lungs function. And next is the response. It is also used in curative procedure like response of the treatment as well the pre-op assessment. If and the last is our disability evolution. So what are the point we have understood here? We will remember that by alphabet wise. First is A for the assessment of the type and severity, of the lung disease, and next C for cough and dyspnea. Okay, and D for that is disability evolution. Okay, and next is monitoring of the response pre-op assessment. Okay, pre-op assessment is included to be remembered with this section. Okay, and this is all about our indication. So we have to remember 5 indication. 2 is the assessment. First is pre-op assessment, and second is the severity of the assessment. Okay, and second A, after that that is disability evolution as well the diagnosis of the dyspnea in case of diagnosis of the cause, or in case of dyspnea and the cough, and monitoring the lung function. What are the contraindications in the pulmonary function test? If patient is having severe asthma, angina, distress, hemoptysis, active TB, or respiratory distress syndrome. These are the 6 conditions where the pulmonary function test is not done. Okay, starting with that, first test is our spirometry. Okay, what is spirometry? It is mainly used to measure the lungs volume and the airflow rate in the instrument. Okay, the volume of the gas in the lungs is divided into volume and the capacity are the two different. Okay, we will study it. First is what is tidal volume. Okay, tidal volume, as we all know, that it is the amount of the gas inhale and exhale during normal breath. Okay, normally patient to be asked to be exhale. After that, starting to the measuring the volume till the complete inhalation. Next is residual volume. What is residual volume? Amount of the gas remaining in the lungs at the end of the maximum. The residual, its name indicate that the total gases, amount of the gas that remain in the lungs. Okay. After that, vital capacity is a total amount of gas that can be exhaled after deep inhalation. Okay, that is the important thing to remember. After deep inhalation, the total amount of gas exhaled is called our vital capacity. Okay, and next is the what is forced vital capacity. It is the maximum volume of the air exhaled maximally forcefully apart after maximally inspiration. Okay, so what's the difference between forced vital capacity and the vital capacity? Is vital capacity is not about here the to understand is it is just exhalation, where what is the here written is maximum volume of air exhaled with maximum force, maximum volume. Okay, forceful expiration is included. After that, the next is vital capacity and the residual volume together constitute is called total lungs capacity. Obviously, after deep inspiration till to the deep expiration is included in our vital capacity, and after that the gas remaining are called the residual. So both are combinedly called our total lungs capacity. Okay. Next is the functional residual capacity. It is the amount of the gas remain in the lungs after the normal and the end of the normal expiration. So what is the forced expiratory volume? Forced expiratory volume in the first second. Okay, if we will after it is the amount of the gas. Look here, it is the amount of the gas exhaled during the first second after inhalation to maximum capacity. Okay, normal FEV is about in the after deep inspiration. When we starting exhaling in the first second, we will remove the air from the lungs, that is around 80%, and the ratio of forced expiratory volume to the forced vital capacity is called FE 1%. Okay, and it is decreased in the patient with the obstructive lung disease. So nextly in the same lecture we are going to cover the obstructive lung disease like asthma and the COPD. Okay, we will go for it. Okay, next continuing our topic, that all the lungs volume can be measured by the spirometry except residual volume, functional residual volume, and the total lungs capacity. We have to remember. So it may be also asked in the viva that what are the volume that are not measured through the spirometry is the residual volume, functional residual capacity, and the total lungs capacity. Okay, these are measure how these above are measured by using the helium dilution as well the body plethysmography. Okay, next is the measurement of the lungs volume can give an idea about the presence and the severity of the obstructive and the restrictive pulmonary dysfunction. It is the important for that we will be using this. Okay, in the obstructive dysfunction, it is characterized by the fall in the ratio of FEV1. That is the very most important point, that in case of the obstructive, FE1 can decrease. Okay, whatever obstructive disease. So what are the causes of the obstructive dysfunction? These include the asthma, COPD, bronchiectasis, bronchiolitis, or airway obstruction. What I have told: A for asthma, B for bronchiectasis or bronchiolitis, C for COPD. These three are the commonly obstructive disorder of the lungs. Okay, you have to remember that. Okay, after that, next is our restrictive dysfunction. This is what I have told, obstructive. Now we will look for restrictive dysfunction. Okay, so it is characterized by the reduction in the lung volume with a normal increase. Okay, remember here the FEV1, that means forced expiratory volume with respect to forced vital capacity is normal, but overall it's both value get decreased, but value will be same. Okay, this condition is used to differentiate the restrictive as well the obstructive disease. After that, cause include what are the cause of the restrictive disease? That is our interstitial lung disease as well the weak respiratory muscle pleural disease or prior lungs resection. What you have to remember: resection as well the pleural lung disease and weak respiratory disease or the interstitial lung disease. For condition also you have to remember there. Okay, now what is next is our peak expiratory flow rate. What is peak expiratory flow rate? It measures the maximum expiratory flow rate over the first 10 millisecond during the forced expiration. Okay, in which the pressure will be high. Okay, and the patient take a deep breath and blow as hard as possible into the instrument. The pointer of the calibrator instrument will show in the main it value will be around 450 to 700 ml, whereas and the 300 to 500 ml for the women. Okay, this is the graph showing the above lungs volume. Okay, and after that peak expiratory force force rate, it is a reduced in air, where PEFR is reduced in case of the airway. Obviously, if there will be narrowing, then we will less force to blow out the air. Okay, next is PEF value less than 200 indicate the severe of airflow obstruction, which where we can see in asthma case of. Okay, so in asthma PEFR is also important, necessary to remember. Remember, if we will understand the basic, then we will not need to learn the data. Okay, we will just write it by understanding. Next is our PEFR monitoring can quantify the asthma severity that I have told now, and it provides the objective measurement for monitoring the response of the therapy. It is also used in the assessment of the response. Okay. After that, predicted value for if PEFR vary with the age, sex, and the height, and it show the diurnal variation. It is the lowest on the first awakening and the highest at a hour later. Okay. After that, it should be measured in the morning before taking bronchodilator, and in the afternoon after taking bronchodilator. Okay, we will just compare the difference at how is it that if our treatment get effective or not, we will use for the assessment of the same. Okay, what the next is diffusing capacity of the lungs carbon monoxide. Okay, it reflects the diffusibility of the gas across the alveolar capillary membrane. It is helpful in evaluation of the patient with a diffuse infiltrative lung disease or emphysema. Okay, where it is used, what you have to understand where it is used and how, why they are using. So what I have told that in emphysema, if there will be a defective ciliary movement, then air will not easily get diffused. So for the check of the diffusion, we will use the CO gas. Okay, same thing will be written here that in DLCO, it is in low asthma, emphysema, interstitial lung disease, whereas it is normal in case of or high in case of asthma, because in asthma there is no any defect in the diffusion process. Only defect is the in its pathway. Okay, a pathway get obstructed due to the edema of the mucosa of our respiratory tract. Okay, so DLCO, it is useful in the screening test for the patient with the AIDS and or suspected with the suspected with pneumocystis pneumoniae. Okay, normal DCLO, it is a strong evidence of the against the pneumocystis pneumoniae. Okay, what is next is next to assessment is our arterial blood gas. What is arterial blood gas? It indicate whenever acid base disturbance, hypoxemia or hypercapnia to be suspected on the same case. Okay, next is our pulse oximetry. What is pulse oximetry? It is a non-invasive method for the monitoring of oxygen saturation. Okay, it is non-invasive method. What it measures, that is oxygen saturation in the blood. So also if a patient is having low oxygen saturation, that patient must have tachypnea. Okay, next is the last is our cardiopulmonary exercise stress test. It is done in patient with unexplained dyspnea. If patient is having dyspnea but reason is not known, then on the same patient should be done. The bicycle, ergometer or treadmill is used. Minute ventilation, expired oxygen, and the carbon dioxide, heart rate, BP, and the respiratory rate are above are the monitor in the cardiopulmonary exercise stress test. Okay, so what you have studied till, we will just summarize in a single point. Okay, so in the pulmonary function test, we started with the vital capacity. Then we will learn the its indication. What are the 5 indication? Assessment, pre-op assessment, and assessment of the severity, and diagnosis of the diagnosis, as well the effectiveness of the our treatment, and monitoring the lungs facility. And the regular screening is done in case of the worker. Okay, and its contraindication is present if is having asthma, pneumonia, asthma, pneumothorax, or angina, or respiratory distress, as well the active TB. So how we will assess them? By using spirometry. First is tidal volume, the normal volume that we exhale to inhale, between exhale to inhale, and next is vital capacity, that also include the maximum inhalation, whereas the forced vital capacity is maximum inhalation to maximum exhalation, and after that total lungs capacity. So overall the lungs capacity and the remaining gas after deep exhalation is called residual volume. Forced expiratory volume is the force during the forceful expiration, the first second volume of the air is called our FEV1, and that is about 80%. And if it get decreased, then it show the obstructive disease, like in case of the asthma or the COPD. And next, another thing is our restrictive disease, that show that where the ratio of the APE V1 divided by total force vital capacity is normal, but overall the value of the both will be get decreased, and some volume cannot be assessed, that is the our residual volume, functional residual volume, as well as total lung capacity, that get assessed by the helium dilution method. And here various obstructive condition. Okay, so if even get decrease in case of obstructive like COPD, asthma, bronchiectasis or bronchiolitis, whereas in the restrictive disease like interstitial lung disease, weakness of the respiratory muscle, pleural disease, and a prior lung rejection. Okay, next is our peak expiratory flow rate. It is the pressure exerted by our lungs during the forceful expiration in the first 10 millisecond is called a peak expiratory flow rate. It get decreased in case of the where the passage get narrow, as in case of the asthma. Its value is 450 to 700 in male and 300 to 500 in case of the female. Okay, next is our diffuse DLCO. It is used to assess the asthma. Here the diffusion capacity of the lungs get assessed. And next is arterial blood gas, that show help in the assessment of hypercapnia. And the pulse oximetry is non-invasive, that measure the oxygen saturation level in our body. And last is our cardiopulmonary exercise stress test. Okay, next is our what are the common sign and the symptom of the respiratory disease, how patient will come to our OPD, and whatever the disease we have to approach by assessing the above. Okay, so how you will remember this, we can wait a second. Okay, healthcare worker. Okay, having healthcare worker have pedal edema. We will memorize this by healthcare worker have pedal edema. Okay, we will memorize it by same. Where we have C by 4. Okay, what is H? H is for hemoptysis. C have 4, that is first is cough, second is chest pain, next is cyanosis as well as clubbing. So cyanosis, clubbing, and cough and chest pain. Okay, and after that worker, W is for our wheezing, and pedal edema. P is for pedal edema, and D is for dyspnea. Okay, what I have told, healthcare worker and a pedal edema. H for hemoptysis, C for cough, cyanosis, clubbing, chest pain, and W is for wheezing, and after that pedal, P for pedal edema, and D is for dyspnea. These are the common and symptoms that presented with our patient. Okay. Okay, now how we will assess the above. Okay, so again we will summarize the same. These are the that is healthcare worker having pedal edema. Next is our what is that, enumerate the cause and the differential diagnosis of the cough. How we will approach the patient of the cough. Okay, how we will approach the patient of the cough, let's see. First of all, what is cough? It is just a protective mechanism through which we try to exhale out whatever the either the pathogen or as well the cough material or whatever the thing present in our or that is responsible for obstruction of our respiratory tract. Okay, so starting cough, it is a forceful expulsion maneuver usually against the closed glottis, and which is associated with the characteristic sound. 3 points you have to remember. First is forceful expulsion, second is by the closed glottis, and third is the producing characteristic sound. Okay, what is the function of the coughing? That is a clearing and a protecting the airway. Okay, it is the most frequent symptom in case of the respiratory disease, and it is the one of the most common cause for which medical consultation is sought. This is the most common problem. As you all know, we have all the routine day we will having the same problem. Okay, so how it get initiated? It is initiated by the irritation of the cough receptor, okay, which exists in the epithelium of the upper and the lower respiratory tract. So what you have to remember that receptor, okay, cough receptor is the important, and that get irritation of the cough receptor. Simple, we have to understand that. Okay, so cough receptor also exists where the cough receptor is presenting pericardium, esophagus, diaphragm, in the stomach. So okay, and irritation of the above also occurs the cough. So impulse from the stimulated cough receptor travel through the afferent nerve, that is our vagus, glossopharyngeal, trigeminal, and a phrenic nerve. You have to remember what are that. That is ninth, 10th, 5th as well the diaphragmatic or phrenic nerve. Okay, what I have told, that is 5th, 9th, 10th. Okay, these are the novimal. And what they do, they stimulate the cup center in the medulla, and the cup center send the efferent signal that travel through the vagus, phrenic and the spinal motor nerve to expiratory muscle that produce the cough. Okay, so explosive quality of the normal cough is lost in patient with the respiratory muscle paralysis. So it is obvious that because how the force get generated by the respiratory muscle, but what if the respiratory muscle get paralysis, then no force pull will be generated, no sound, enough sound will be produced. So in case of respiratory paralysis as well the vocal cord palsy. Okay, that you have to 2 point we have to remember. Next is our vocal cord palsy give rise to the low pitch inefficient bovine cough. Okay, obviously it will vary, like the cow will produce the sound a low level of sound. Okay, so what are the cause of coughing? Okay, so in case of the acute cough, when we will call it acute, if duration is 3 week and subacute duration is 3 to 8 week, and if it is more than 8 week, then we will call it chronic cough. Okay, so what are the cause of the acute cough? First is the upper respiratory tract infection like common cold, pharyngitis, acute bronchiolitis, aspiration, event or inhalation of the noxious chemical, smoke or pulmonary embolism. Very simple to memorize. How we will? First is our A for aspiration event, B for bronchitis, C is for chemical or cold. Okay, and D, no D. Then next is our E is for embolism, so pulmonary embolism. This is way we remember by acute cough. Next is our subacute. Subacute case is seen in case of, that is our tracheobronchitis or a patient with pertussis and a post-viral tussive syndrome. In a chronic cough, it is present seen in patient with asthma, COPD, bronchiogenic carcinoma, tuberculosis, bronchiectasis, and tropical pulmonary eosinophilia, postnasal drip, GERD, and interstitial lung disease, pulmonary edema, or cardiac failure, or ACE inhibitor. In our case, we will see with chronic cough. So next is our during the history, what we will go for. First is our age and sex. Okay, normally as we all know that bronchial carcinoma and COPD are more common in the elder male. Okay, whereas the asthma is more common in the female. Next is its onset. How it get onset? It is associated with the patient will associated with like expression of the foreign body, allergic reaction, as well the pulmonary edema due to the left ventricle failure. Insidious onset of the cough occur in case of COPD. That is very important to remember. So if patient is having sudden onset, okay, insidious onset in case of the COPD, interstitial lung disease, chronic lung disease, and a TB. Okay. Next, if the cough is productive or the dry cough. So what the its significance? It signifies that significant sputum productions suggest primary pulmonary pathology. Okay, if the sputum is produced, then pathology is on our lungs part, that is pneumonia or abscess of the lung or bronchiectasis. Whereas dry cough, if there will be dry cough, then patient is pathology is in our upper respiratory tract, that is our rhinitis or pharyngitis. Next is our what are the associated symptoms presented. Okay, presence of the wheezing along with cough. Okay, here if wheezing present along with cough, then patient may have bronchial asthma, acute bronchitis, COPD, eosinophilic pneumonia, tropical pulmonary eosinophilia, and presence of the breathlessness can also occur in pneumonia. Okay, and acute, that is also important, acute excavation of the asthma and COPD or significant pleural pathology. Okay, if patient will also have fever also. Okay, if patient will have fever also, then must be it will show about infectious case. Okay, next is the diurnal variation of the cough. If patient is having diurnal variation of the cough, then asthma, as we all know that during early morning asthma get excavated, and cough due to GERD may also increase after the food intake. Okay, you have to just remember the condition. Okay, and if you will remember like in asthma and GERD, then automatic you will remember the time. If you have known the topic of the diurnal variation, you have to mention it in your exam as well, the viva. Okay, and at the night time of the recumbent position, pulmonary edema due to heart failure can cause cough at night. Okay, these are the 3 points you have to remember. asthma in the morning cough, GRD after taking food, and a pulmonary edema during the cough at night. Okay, intake of a medication like ACE inhibitor also can cause the cough. Okay, next is our smoking. How smoking, it is one of the commonest cause of the persistent cough, as we all know, and it will also smoking will lead to COPD and the lungs cancer. Occupation like the chemical exposure, for example coal mine worker may also have chronic cough. So how you will investigate the case of the coughing, what and the finding you have, and how you will approach it. Starting with acute cough usually do not require any investigation, it should be treated symptomatically. Okay, antitussive is given for the dry cough, and the expectorant is given for the productive cough that we are routinely using. Okay, next is our indication of the investigation in case of acute is required in case of the hemoptysis, prominent systemic illness, and the suspension of the inhaled foreign body, or suspension of the lung cancer. Okay, however chronic may require the, what are the investigation in the chronic routinely using our chest x-ray that show the any, if any pleural or parenchyma or pathology like the effusion, pneumonia or mass lesion will be present, that we use for the chest. Or after that sinus imaging x-ray or the CT scan to be, it is used to rule out the sinus condition. And spirometry, it is as earlier we have studied before a minute, that are done in all patients in case of the, in all cases of the chronic cough we can have to assess the by spirometry. Okay, it is helpful in diagnosis of the asthma and the COPD. Next is the HRCT, called a high resolution computed tomography. Okay, it is useful in diagnosis of the bronchiectasis, interstitial lung disease, and the dilation and the evolution of the lungs pathology. Next is our bronchial provocation test. It should be done in patient without clinically etiology of the cough. If etiology is not known for a period of the while, then we'll go for bronchial provocation test. Next is our bronchoscopy. It is done if the inhalation of the foreign body as well the endobrachial pathology is suspected. Okay, 24-hour esophageal pH monitoring also done in case of the GRD. And so how you will treat the above case, how will treat the patient with cough. Okay, so as symptomatic treatment, as I have told earlier, that in case of management of cough involve the cough suppression will be given like codeine, dextro, methorphan, and levocloperestin for dry cough, and expectorant for the productive cough. Do not suppress remember you have to that in case of productive cough no need to suppress, just expel out the content. Okay, that will decrease the chance of the disease. Okay, so what are the complication can occur during this? Complication like syncope, rib fracture, or pneumothorax, or development of hernia can also occur due to if the patient will having persistence of cough. Okay, so just summarize the what you have studied till in the cough. So first of all, we have read about the cough. Its definition, it consists of the three part, that is our forceful expulsion, glottis to be closed, as well the produce specific sound. Okay, function of the coughing is to clearing and protecting the respiratory tract. Mechanism is due to the irritation of the cough receptor, and vagus efferent nerve involved are the fifth, ninth, then plus phrenic nerve and efferent are by the spinal nerve that contract the respiratory muscle, as well the diaphragmatic nerve, and that stimulate the cough center present in our medulla. And after that, if a patient is having difficulty in coughing or no sound is produced, then there may be chance of the vocal cord palsy, as the respiratory muscle palsy. After that, causes of the cough is found, that may be divided in three category: acute, chronic, and acute, subacute, and chronic. Acute is less than 3 weeks. Common cause or remembered by the ABCD, that is aspiration event before bronchiectasis, C for the common cold and the chemical, and for the subacute only two reasons to be studied, that is the tracheobronchitis and tracheobronchitis and pertussis. For the chronic cough, asthma, COPD, bronchogenic carcinoma, bronchiectasis, and tropical pulmonary eosinophilia, postnasal drip is given. And in age we have studied that asthma is common in female, as well the bronchogenic carcinoma is common in our male. And how the onset may be acute or the chronic. If the patient is having acute, then we will just go with symptomatic treatment, as well the patient may have chance of the foreign body aspiration, left ventricle failure, or other cause like chronic infection in case of the TB. After that, if the cough is dry cough then must be due to irritation of the upper tract, whereas the maybe if cough is wet cough then must be pathology present in our lungs. Okay, so associated symptom may be wheezing. If present with wheezing, then patient may have the bronchial asthma, acute bronchitis, COPD, eosinophilia, pneumonia, whereas if acute exacerbation of the asthma or COPD may also be seen. If present with fever, then must be due to infection. And diurnal variation like asthma excreted in the morning and pulmonary at the night, whereas GRD is after the taking of the food. Drug also like ACE inhibitor also stimulate, and smoking is the most common cause, and at the end leading to the lungs cancer. Occupation like the chemical exposure, coal mine worker also develop chronic cough. Okay, investigation includes the symptomatic treatment like antitussive for dry and expectorant for the productive cough, and chest X-ray like the pleural or the parenchyma pathology like effusion, pneumonia, and the mass lesion is be done. Okay, for the sinus imaging, X-ray or the CT scan to be done and to be ruled out. For sinusitis, spirometry is earlier studied that for the chronic cough and asthma we are using that. HRCT is used for the lungs pathology like bronchiectasis, interstitial lung disease, as well the evolution of the any lungs pathology. Okay, and next is the bronchial provocation test should be done to find out the etiology in where the uh, in case of unknown. And bronchoscopy is also done if the inhalation of the foreign body or the bronchial pathology is done, and 24-hour esophageal pH monitoring is done in case of GRD. For treatment, we will go for symptomatic cough suppressant like the codeine or dextromethorphan is used, whereas expectorant in case of productive. And the complication will lead to complication are like the common are hernia, pneumothorax, as well the rib fracture. Okay, due to excess of the pressure, ribs may also get fractured. Okay, these are all about our coughing. Okay, next is our what is clubbing, its mechanism and how it occur, and how you will assess the case of the or maintain the case of regulate the case of the clubbing. Okay, starting. Okay, so what is clubbing? Just it is nothing, just the enlargement of the soft tissue in the terminal phalanges leading to the both transverse and the longitudinal curving of the nail is occur. Okay, next is our longitudinal curving of the nail lead to the loss of the angle between the nail as well the nail bed. Okay, and normal angle is less than 160 degree. If the curving is it is more than the 160, normal angle is less than 60 degree. If it is clubbing is occurred, then it will be get less. Okay, so grading is done into the four staging. That is very much important in case of the viva point of view. First is the softening of the nail bed will be occur, and the fluctuation is present in this stage. Second point is our loss of the angle between nail and the nail bed, and next is the parodic appearance in the nail as well the drumstick appearance of the digit. Next is our in the case of the grade 4, swelling of the finger and the all dimension associated with the hypertrophic pulmonary osteoarthropathy. In the next lecture, we will look at diagram for the staging. Okay, what is the mechanism of clubbing? Really, it is don't know, but it is believed that the chronic hypoxia. Okay, it is a triggering factor for development of the clubbing. Okay, chronic hypoxia lead to opening of the arteriovenous fistula, which increase the blood supply to the digit, and at the end leading to the soft tissue hypertrophy. Okay, so just summarize. Okay, look here. This is simple diagram showing that if the patient is having, okay, like this angle. Okay, this angle is normally usually less than 160 degree, but what if increase? Okay, so if this angle get increased more than 80 degree, then it is considering in the clubbing. By the time more the clubbing occur, more the severity increase, then more the angle will be there. Okay, so after that summarizing the clubbing, what is this? It is the enlargement of the soft tissue of the terminal phalanges in the both direction, transverse as well the longitudinal. Normal angle is less than 160 degree, but when it is more than 180 more than 60 degree, clubbing to be said to be present. Okay, and the grading of the clubbing, in the first degree there will be softening as well the fluctuation present. In the second degree there is the loss of the angle between nail and the nail bed, and in the third degree parodic appearance as well the drumstick appearance of the digit is present. In the fourth degree or grade 4, all the dimension associated with hypertrophic pulmonary osteoarthropathy to be done. Mechanism is don't know, but it is to be think that it may be due to chronic hypoxia leading to AV fistula, which increase the blood supply to digit, as well the toe leading to the toes leading to soft tissue hypertrophy. Okay, so in which condition causing of the, what are the common cause of the clubbing seen, where the clubbing seen? Okay, that is the pulmonary tuberculosis, lung abscess, bronchiectasis, bronchocarcinoma, mesothelioma, interstitial lung disease, emphysema, cystic fibrosis. In cardiovascular case like infective endocarditis, cyanotic congenital heart disease, atrial myxoma, GIT like ulcerative colitis, Crohn's disease, primary biliary cirrhosis, hepatocellular carcinoma, endocrine acromegaly, myxedema, and in case of miscellaneous like hereditary unilateral clubbing or unidigital clubbing or idiopathic. This is all about our clubbing. Okay, now we are going to cover, that is our dyspnea. What is dyspnea? What are the cause of dyspnea? What is dyspnea? It is simply, we will call it breathing difficulty. Okay, or by abnormal or uncomfortable awareness for our breathing. Okay, let's look it in detail. What is the question? Define dyspnea. What are the mechanism of dyspnea? Enumerate the cause of dyspnea, as well as differentiate diagnosis in case of the acute onset dyspnea. Let's begin our topic. Dyspnea, it is nothing just called breathlessness. It refers to the abnormality and the uncomfortable awareness of the breathing. Dyspnea, it may be acute as well as chronic. Okay, acute, that means breathing in difficulty within minute to hours, whereas chronic is from difficulty since month to week. Okay, so what are the mechanism of dyspnea? Why the person get difficulty in the breathing? First is due to the stimulation of the intrapulmonary sensory nerve. In case like the interstitial inflammation or pulmonary embolism, it will irritate our sensory nerve, and that will produce breathing difficulty. Next is our increasing in the mechanism load of the respiratory muscle. If the load of the respiratory muscle get increased, in case of the obstruction or pulmonary fibrosis, obviously imagine if this patient is having pulmonary fibrosis, patient is using forcefully or trying to, obviously patient will get difficulty in the breathing. Next is the stimulation of the chemoreceptor, like in case of the hypoxia, hypercapnia or acidosis. Okay, last is the reduction in the lungs compliance in case of the pulmonary edema, severe kyphoscoliosis, pleural effusion, and the pneumothorax. Okay, so we have studied the four conditions. First is the stimulation of the intrapulmonary sensory nerve. Second is the mechanical load of the respiratory muscle. Third is stimulation of chemoreceptor, and fourth is reduction in the lung compliance. Okay, so here it is the cause of the acute dyspnea, like in cardiovascular case like the acute pulmonary edema, acute myocardial ischemia or cardiac tamponade. In respiratory case like severe asthma, aggravation of COPD, pneumothorax, pneumonia, pulmonary embolism, ARDS, foreign body aspiration, laryngeal edema. Okay, and the metabolic acidosis and the psychogenic hyperventilation are also caused, whereas the cause of the chronic are the chronic heart failure, ISD, COPD, chronic asthma, bronchiogenic carcinoma, interstitial lung disease, chronic pulmonary thromboembolism, pulmonary effusion, and severe anemia, as well the obesity. Okay, now this is all about. Okay, next topic is our, what is the solitary pulmonary nodule? What is solitary pulmonary nodule? Simple topic, it's one of the simplest one. Okay, let's study. It is just nothing, just a coin like lesion, less than 3 centimeter in size, present, that is in the both within and surrounding the pulmonary parenchyma. Okay, it is nodule, also called a mass. Its size is around 3 to 4 centimeter. It is the common clinical problem detected incidentally on the chest X-ray as well as CT scan. What are the differential diagnosis? It is differential diagnosis. The main question is that has to be answer is whether it is malignant or benign. Okay, so in benign case, where it is seen, like in case of infectious granulomatous Wegener granuloma, and localized pneumonia, lung abscess, pulmonary infarct, AV malformation, hematoma, hydatid cyst, bronchiogenic cyst, rheumatoid nodule, pulmonary sequestration, pulmonary hematoma, and in the above case. Whereas malignant cause can be seen in case of pulmonary lungs cancer or carcinoid syndrome, single metastasis, and lymphoma. Okay, how you will diagnose it? By how first our main task is to differentiate whether it is malignant and the benign. Okay, next is the whereas, okay, look here, if malignant should be excised and the benign should be left behind. Okay, and it is not always possible to distinguish between the malignant and benign non-invasively. However, in certain clinical and radiological feature help in the just to know the case. Okay, what are the clinical feature? it is more chance in case of the malignancy if age is advanced, that is more than the 50% nodule, and a malignant at the age of more than 60. History of smoking or asbestosis exposure, previous history of the malignancy. Okay, radiographic features suggestive of the malignancy are the its size, large lesion are more likely to be malignant, and a smaller lesion, okay, irregular border like growth and a faster growing nodule are likely to be more chance that to be malignant. Okay, next is how you will investigate it. For investigation, chest x-ray, CT scan, PET scan, FNAC to be done, and for its management, if the probability of the nodule to be malignant is high, it should be resected out, okay, such that it will not spread anymore. If the probability of the nodule of the malignancy is low, let it be. By the time it will resolve it either, or it will, if it is not convert causing any uncomfortability. Okay, next question is hemoptysis. What is hemoptysis? Or blood during the cough. In cough there is blood is also present. So hemoptysis is the cough out of the blood that originate below the vocal cord. Okay, obviously if blood is source of origin of blood is below the vocal cord, then it will call it hemoptysis. It is the often serious sign of the disease. Okay, non-pulmonary source of the hemorrhage from the nodes, nose and GIT will be excluded. Okay, so look here, one of the very important thing to remember here is if the source of bleeding is below the vocal cord, then it will present as hemoptysis. Whereas if the bleeding is either from the GI tract as well the nasal cavity, then it will present through the nasal part. Okay, blood will come out through the nasal part. You have to remember that. Okay, next is it is classified as the trivial, mild or massive. What is massive hemoptysis? It refers to the expectoration of the large amount of the blood to a rapid rate of the bleeding. There is no universal acceptance of the blood volume defined the massive hemoptysis, but generally more than 200 to 600 ml in 24 hours is considered to be massive hemoptysis. Okay, so next is a useful clinical definition for massive hemoptysis is that resulting in the life-threatening event including the severe airway obstruction, significant abnormal gas exchange or hemodynamic instability. Okay, it is better to use the term life-threatening hemoptysis rather than massive hemoptysis. Next is our lung have two sources of the blood supply: the pulmonary artery which arise from the right ventricle and the bronchial artery which arise from the aorta, and the intercostal artery both supply the lungs. Okay, the bronchial artery circulation, it is the high pressure circuit, through it contribute to only 1 to 2% of the total blood flow, and the bronchial circulation is frequently the source of the hemoptysis. So where in which case hemoptysis is seen in case of the TB, chronic bronchitis, bronchiectasis, bronchogenic carcinoma, bronchial adenoma, aspergilloma, and primary embolism, pneumonia, lung abscess, AV malformation. In cardiac case like left ventricle failure, mitral stenosis, hematological like thrombocytopenia, hemophilia, DIC. Okay, so what are the clinical features? Patient will say that they will have history of the blood sticking of the stomach, sputum. Okay, patient is usually get anxious because it is like scary for them, and massive hemoptysis is seen in case of the this is the one of important thing. Look again, that massive hemoptysis may have sign of hemodynamic compromise such as tachycardia, hypotension and a cold periphery. Symptom and the sign of the underlying disease of the hemoptysis may also be present. For that, investigation like chest x-ray, hemoglobin, PCV, CVC and a platelet count, renal function test, urine analysis, coagulation test to be done. Okay, high resolution CT can be done in case of unsuspected where the pathology may be bronchiectasis, AV malformation, or so the central endobronchial lesion. Okay, rigid fibro-optic bronchoscopy can be done if the cause of hemoptysis is not evident for non-invasive. How you will manage? It will be managed first to be identified as well as treated. Massive hemoptysis, for that ABC, airway, breathing and the circulation to be maintained first. Okay, and after that patient should be placed in the lateral decubitus with the involved the lung dependence so that the blood does not enter the lungs. Okay, and the volume expansion by the using IV fluid and the blood transfusion is required to maintain the blood circulation. Next is cough suppression is also given codeine such that less to be coughing, less blood to be out. Okay, next is our nebulized adrenaline can also be given to vasoconstriction so that if the vasoconstrictor will be given, it will constrict the vessel, less blood to be oozed out. Next is tranexamic acid also stop the bleeding, and in case of the uncontrolled hemoptysis, wait, in case of the uncontrolled hemoptysis need to be rigid bronchoscopy and a specific intervention to be done like angiography as well the embolization. Okay, lungs resection should be also considered if bleeding is on the local side or not responding to any above measure. Thank you, have a great day.